So what is an exodeviation? Exodeviation or exotropia is basically a form of squint or strabismus where one or both the eyes will deviate basically outwards. This means that the eye is actually deviating away from the nose. Here in this picture you can see that the left eye is deviating away from the nose. That is, we are looking at a left exodeviation. Now, another important point that I want you to know is regarding the nature of exodeviation. Now, the exodeviation or exotropia can be actually be constant in one eye. That means it can be present all the time, or it can be alternative in nature. That means sometimes it can be present in the right eye and sometimes it can present in the left eye. Now, the alternate exotropia or exodeviation can also show sometimes preferences. It means that the right eye, for example, you have alternate exotropia with right eye preference. It means that although the exotropia alternates between the right eye and the left eye, still the patient has preference for the right eye. That means the right eye is deviating much more compared to the left eye. Similarly, if there's a left eye preference of exotropia, it means that although both the eyes are alternating, the left eye is deviating more number of times compared to the right eye. Also, the exodeviation sometimes might be present only for a limited duration of the time, and rest of the time the patient would actually be having straight gaze or orthotropia. Now, such a deviation is known as intermittent, and in exodeviation it is known as intermittent exodeviation. Now, exotropia or exodeviations can also be associated with vertical deviations like hypertropia or hypotropia. Apart from that, your exodeviations can also be associated with patterns like the A pattern and the V pattern or the X and Y patterns. Alright, now before we proceed, it is very important to know some terminology. And here we shall be talking about what is meant by exophoria, intermittent exotropia, and exotropia. So, first, let us discuss what exactly is meant by the exophoria. So, as you can see over here, exophoria basically is a term used when the outward deviation is never seen in a manifest state. Okay, so when you see a patient of exophoria, the patient is going to look absolutely normal to you with straight eyes. Okay, it's only when you do the alternate cover test that you're going to see the inward movements of the eyes. Okay, so that is known as a phoria state, and when the eyes are actually moving inwards under the alternate cover test, that is known as the exophoria. Okay, now next is the intermittent exotropia. As the name suggests here, the outward deviation is seen sometimes, but it can actually be controlled by fusion or accommodation or convergence. Okay, so what I mean to say is that sometimes the patient is going to be orthotropic. That means the times when the patient is able to control or maintain the straight gaze by his fusion or accommodative or convergence facility. And other times, suppose the patient is really fatigued or he has some illness, viral illness or something like that. In those cases, the patient will not be able to maintain that fusion, and usually in the late hours of the day, that time the patient will have very obvious outward deviation of the eye. Now, such an exotropia is known as intermittent exotropia, which appears only during certain times of the day. For example, late during the day when the patient is tired, or the patient has read for longer duration of time, or there's any fatigue or viral illness, or immediately after waking up. So that is known as intermittent exotropia. Alright, then we have constant exotropia where the deviation is seen all the time, right? So it's seen constantly, and in other words, it's also known as manifest exotropia because the deviation has manifested itself all the times. Now let's talk about the prevalence. Now, when we talk about the exotropia, in the exotropia, it is the intermittent exotropia, which is the most common type of strabismus seen in children as well as also the adults. Okay, especially it is seen in the Asian and South Asian population, and regions which are closer to the equator, they have higher prevalence of the exodeviations, and it is more common in women. And when we are talking about the Asian and South Asian population, here the prevalence of exotropia is about 7 to 18.5 times higher than that of esotropia as well. And as I told you, the most common type of exodeviation that we see is the intermittent exotropia, accounting for about 63% of the cases. Now, you might be thinking, what exactly is this X bracket T? Okay, so we'll talk about those symbols in a while. Now, completing the prevalence, the exotropia can also start at birth. Okay, but what happens is that at the time of birth, the child, or you can say in infancy or in childhood, the kids usually have a great deal of fusion accommodation and a really robust convergence, right? So often, if you ask the parents if the exotropia or outward deviation was present since birth, they wouldn't really be able to answer, as it was taken care of by the robust or strong convergence in the childhood, right? Later on in life, as that decompensates, or what I mean to say is as the fusion weakens or the convergence weakens, then the exodeviation becomes more apparent and more constant, and that is something we call as a manifest squint or manifest exodeviation, right? So basically, you're not going to see an exodeviation right at the birth, although the process starts at birth. Now, so if there's a child that has exotropia right from the childhood, which is also known as the congenital exotropia, now it basically means that the child is going to do really poorly later on. Okay, so there's going to be poor prognosis of congenital exotropia. Why is that so? It's because the child who has had this deviation right from the start of the childhood will actually have no orthotropic periods. Okay, this child will never have had any straight eyes, right? And therefore would not have gotten any chance for normal binocular single vision development. That means they are going to have really poor binocular single vision. And that's the reason why congenital exotropia has poor prognosis. Okay, so if the parents tell you that the deviation was present right since birth or right since 6 months of age, it means it's poor prognosis. Okay, now if you want to know more about the binocular single vision, you can refer to the video on our channel. The link is going to be provided in the description box. Alright, now let's talk about some of these symbols. Okay, so I hope you understood what exactly is meant by exophoria. And exophoria is basically represented like this. Okay, so you can see over here how an exophoria is represented. So it's represented like this. And then you have the intermittent exotropia, where you use brackets around the T. And in exotropia, you simply write XT. And then sometimes we also use this denotion, this symbol, which is known as BI. Okay, base in, and also use divergent squint DS. Now the question is, why exactly are we using this BI and divergent squint? Okay, so for example, you can see over here, and if you would remember the video on the prism cover test and the cover test, second part, so you would know how do we actually carry out a prism bar cover test or the loose prism test. The prisms that we use for measuring the deviation usually are presented to the patient, or they are put in front of the patient in such a way that the apex points towards the deviation. So when we are talking about the exotropia, the deviation is outside, right? And therefore, the apex is also going to be directed away from the nose, and automatically the base is going to be towards inside, that is towards the nose. And that is the reason why the prism that we use in case of exotropia is referred to as a base in prism. All right. Now, such a patient, when they are being measured with prism cover test, for example, this patient, okay, over here, say with 40 prism diopter of base in prism, there is no redressal movement on cover test. We say that the patient has left eye exotropia of about 40 prism diopters base in, or we can also refer to it as 40 prism diopters BI or 40 prism diopters XT. Okay, so it means a manifest squint or a constant squint. Okay, so remember, exophoria has that small apostrophe on top of that. Intermittent exotropia has the brackets around the T. Exotropia is just written as XT. BI is basin, used for the exotropia. And similarly for esotropia, we would be using what? Base out. BO is the denotion. Okay, and divergent squint also, because it's a diverging kind of squint. Okay, so you can refer to these videos. The links are going to be given in the description box. And now let us try to discuss exactly what exactly causes exodeviation. Now, unfortunately, so many scientists and so many causes, there isn't really a consensus and one single cause as to what causes exotropia. And that is the reason why I decided to make a detailed video, so that you can understand the pathophysiology in detail. And we shall try to simplify all of that for you. So now let us begin. We totally have around 7 causes of exodeviation that we shall be discussing in this video. The first one was actually given by Duans, okay, and he referred it to as the innervational theory based on the innervational factor. So what does this innervation means to you? Innervation means that it has something to do with the nerve supply of the muscles, right? So we know that during convergence, it is the MR which will get the innervation, and both the eyes are going to move inwards. Whereas in the case of divergence, both the eyes are going to move outwards and the innervation goes to LR. Right, so there's kind of a tug of war going between the convergence and divergence. Now, ideally, you might be thinking that there must be some equilibrium, but that really doesn't happen, right? Okay, so you should know that during the normal, whenever we do some near task, it is the normal convergence that takes the dominance, right? And what exactly is meant by normal divergence? Normal divergence basically refers to the ability of the eye to move outwards away from each other in a very coordinated manner. And actually speaking, this outward movement is required when you're shifting the gaze from a near object to a distant one, and this allows the eyes to maintain a proper alignment and focus on that distant object, right? Now over here in exodeviation, there's actually an imbalance between the convergence and divergence mechanism. Now obviously it's a no-brainer that the divergence is much more in exodeviation compared to the convergence, but mind you that I'm not talking about the normal divergence. Okay, so what we are talking about over here is the tonic divergence. Okay, so in exodeviation they have what is known as hyperactive tonic divergence, which is causing an outward drift. Now you might be thinking what exactly is meant by this tonic hyper divergence. Okay, now the normal divergence that we talked about was basically in response to a visual stimulus. That means a distant object that you wanted to look at, right? But over here, the tonic divergence refers to that baseline level of divergence which is present even when there's no active visual stimulus. That means even when the eyes are at rest. Okay, so it is thought to result from tonic constant activity of the divergence system which is present in the brainstem. Okay, and it is this tonic divergence which is going to actually help set the resting position of the eyes, and this is known as the physiological position of the rest. Okay, and the physiological position of the rest is actually slightly divergent. Okay, so that is one point that you must remember. Okay, so in normal functioning eyes, the tonic divergence is just going to help the eyes maintain that alignment and avoid that excessive drifting of the eyeball outwards whenever the visual system is not really engaged in a task, right? However, if the patient has this excessive tonic divergence, it can contribute to exodeviation where the eyes are going to deviate outwards. So I hope you understood that. All right. Now, in childhood, what happens is that the convergence is pretty strong, and that can actually mask the deviation present at near. Okay, so we know that convergence comes into play during the near task, and in childhood, they actually have a really strong, robust convergence, and therefore, whenever the child is going to look at near object, the exodeviation is going to automatically disappear, right? And that is something which I wanted you to know. Apart from that, there's another entity which is known as infantile exotropia. Now, infantile exotropia is a very rare form of strabismus, which is actually characterized by this deviation, outward deviation of one eye or both the eyes, that is going to appear shortly after birth or within the first 6 months of life. Okay, so remember the time period. It's shortly after birth or within the first 6 months of the life. Okay, now there are certain characteristics of infantile exotropia that we shall enumerate now itself. So number one is early onset, usually detected in the first 6 months of life. Second is really large angle deviation. The exotropia is often large with deviation of 30 to 50 prism diopters or even more. And what did I tell you? The binocular vision is going to be really poor, associated with almost absent binocular vision and little to no potential for fusion and stereopsis. Okay. And apart from that, they will have associated ocular neurological abnormalities. They will have developmental delays compared to other type of exotropia. And such kids usually need early surgical intervention because conservative treatments like patching and glasses are not going to work in them. right? So over here, let me remind you that it's very important that you understand what exactly is binocular single vision before you jump into these topics of squint, and therefore I would highly recommend that you visit our video on BSV. All right. Now, the second theory was given by Bilchowski theory, and this theory basically says that it's not just the innervational factors, but it's also the mechanical factors which are responsible for the development of exotropia. So, it could be the shape and orientation of the orbit. For example, you take the variation in the size, shape, and orientation of the orbit, that means the sockets, can actually affect how exactly the eyes are positioned and how exactly the eyes are going to move inside that socket. Okay, for instance, if someone has a really wide socket or more horizontally aligned, it is going to make it easier for the eyeball to drift outwards. Okay, so that is how the shape of the orbit is going to decide the position of the eye. Similarly, the size, the elasticity of the muscle, and the insertion point of the muscle is really going to impact how exactly the muscles are going to control the movement of the eye. For example, if the lateral rectus muscle, which is actually responsible for the outward movement, say is overacting, what exactly is going to happen? Okay, or what I mean to say is, suppose the lateral rectus muscle is more elastic, for example, what is going to happen? It is going to have this tendency to move the eyeball outwards, leading to exotropia. Similarly, if the medial rectus is really, what do you say, lanky or long and without any elasticity, what is going to happen? It is not going to be able to pull the eye towards the midline, and therefore again it is going to cause exodeviation. So definitely again a mechanical factor over here. Similarly, the surrounding tissues also is going to play a role in the determination of whether the patient is going to develop exotropia or not. Okay, the volume, the viscosity of the retrobulbar tissue. What I mean to say is the orbital fat. So what exactly is present behind the eye? It is the orbital fat and other tissues, right? So whenever there's an increase or decrease in the volume of the retrobulbar tissue behind the eye, including the fat, that can cause mechanical displacement of the eye. Okay, for example, suppose the tissue is increased. Suppose there is some tumor over here in the retrobulbar area. What is going to happen? That is going to push the eyeball outwards and also slightly, away from the nose, leading to exotropia, right? Similarly, scar tissue, fibrosis, all these things can actually cause they can actually cause the development of squint and exodeviation, right? So this is why we actually do our forced action test, because we want to rule out the scar tissues and fibrosis. So what happens is that if there's any scar tissue which has fibroblasts around that extraocular muscles or surrounding the orbital tissues, it can actually mechanically restrict the normal eye movements, potentially leading to exotropia. Right? So what, for example, this is lateral rectus and you have some surgery around the lateral rectus before or around the orbit. What happens is there's a fibrous growth near this lateral rectus, which is going to prevent the relaxation of the lateral rectus. So what will happen? This fibrotic tissue is going to constantly pull on the lateral rectus, tug on the lateral rectus, and also pull the eyeball laterally, right? This is how a scar tissue or fibrosis can cause the development of exodeviation, right? So mechanical factors do play a role along with the innervational factor, and that was the second theory. An example of this is the Crouzon and Eppert syndrome. High prevalence of exodeviation is seen in these patients. They have this craniofacial dystosis, okay, premature fusion of their sutures, so that leads to development of really shallow and laterally directed orbits, and because of that, even the eyeballs which are sitting inside the orbits will seem to be as if they are laterally directed. Okay, that is what is meant by, that is what is called as exotropia. All right, now let us talk about the third theory, that basically is based on the role of defective fusion in the development of exodeviation. Now, what exactly is meant by fusion? Now, in our previous videos also I told you that the fusion by the eyes basically refers to the brain's ability to combine the images which are coming from both eyes into a single unified image, allowing us to have that depth perception and binocular single vision. Okay, so normally what's going to happen, the right eye is going to see one image, the left is going to see one image. Both these images are going to fall on the fovea of the two eyes, considering that they are orthotropic. Okay, and these two images are going to be fused together into a single image by whom? By brain, right? And this is known as the fusion faculty. Usually if the fusion faculty is good, The patient is going to have a good control of exotropia and usually will be in the initial pathophysiology, that means in the exophoric state or exophoria. However, if the fusion is poor, then the patient is going to actually progress in the pathogenesis of the exotropia and can actually become intermittent exotropic or can have even more worse thing which is known as the constant exotropia. Okay, so in our previous video we talked about what exactly is meant by sensory fusion and motor fusion, and to understand it's very important to understand these two concepts in order to understand why defective fusion leads to progression of exotropia. Okay, so as I told you in simple language, unification of those two visual excitations or two visual images that are coming from both the eyes, because these images are falling on the corresponding points on the retina. Okay, that unification is known as fusion, and it is simply done by our brain. Okay, so that is what is known as sensory fusion. However, what exactly is motor fusion? Now, motor fusion is something which is the ability for the eyes to align themselves in such a way that the sensory fusion can actually takes place. Okay, so motor fusion basically depends on the extrafoveal retinal periphery. Okay, it depends upon what exactly is the retinomotor value of the retinal elements. Okay, so don't get scared. We have all of this covered in our video on binocular single vision. You can go and check out that video and come back to this video. Okay, so basically what I mean to say is that in exotropia or in esotropia, when the eyes are deviated, the rays are not going to fall on the fovea. Instead, they are going to fall on an extrafoveal element. Okay, and the eyes also know that they are actually forming the image on a wrong part of the retina, and therefore the eyes are actually going to make a corrective movement to align themselves. Okay, now this happens to a certain degree, and this is known as motor fusion. Okay, so sensory fusion is something that happens at the level of the brain, whereas motor fusion basically happens at the level of the eyes. Okay, so motor fusion is something what our eyes do. Okay, so you can actually know about this in detail in the first part of binocular single vision, and in the second part, which is confusion versus diplopia, you can actually figure out about the other things as well. All right, so we are talking about this sensory fusion, motor fusion, taking care of everything, aligning the eyes, but everything happens to a certain limit, right? There's a limit to everything. And how long will the brain or how long will the eyes actually compensate and try to keep them straight? So what happens over here is that in the normal conditions, under normal conditions, when the patient has normal sensory fusion, motor fusion, that means normal brain and normal eyes, okay, which are able to align well. Okay, so at that time the patient might just have a latent outward deviation which is known as exophoria. Why is it latent? Because the patient can use their fusional reserves, that is a fusional convergence, to keep their eyes aligned, right? Now, these reserves are actually an extra effort the brain and the eye muscles are using to pull the eyes inwards and maintaining the proper alignment. All right. Now, when that fusional reserve becomes insufficient or they fail, now they can fail because of a variety of reasons. Either the medial rectus becomes weaker for some reason, or the patient is constantly using fusion, so the patient is getting tired, or something like that, fatigue. So what happens now? The deviation will now start getting manifested for longer duration of time, and that is known as intermittent exotropia. And when the fusion capacity becomes even more worse, what exactly is going to happen? Then the patient is going to have something which is known as constant exotropia. That means the deviation is actually manifest all the time. That means in such patients you would be actually able to see clear-cut deviation all the time. All right, now let's talk about the fourth reason related to the exodeviation development, and that is the sensory adaptations and suppression. Now we know that, for example, over here you can see this is the right eye of the patient, and the right eye is showing exotropia. Now, what exactly happens is that when the eye deviates outside or away from the nose, you can see that the rays which were initially meant to fall on the fovea are now falling on the temporal retina, and therefore the image which was supposed to be here overlapping with the black image which is coming from the left eye is now falling on the other side nasal to that black dot. That means the patient is experiencing something known as double vision or diplopia, right? And the type of diplopia that we see in case of exotropia is a crossed diplopia, right? Now, what exactly is brain going to do to deal with this diplopia or double vision? Very simple. The brain is just going to suppress it, right? So in cases where the fusion is deficient, so what I mean to say is initially the eyes and the brains, they try to basically do what is known as fusion. Okay, they try to fuse those two images. But if that is not possible, especially when the development of exotropia is later in the life, okay, that time the brain is trying a brain will actually try to suppress that extra image, right? So if the suppression is at the fovea, it is known as central suppression, and if the peripheral part of the retina is getting suppressed, that is known as peripheral suppression. Now, for this suppression to develop as well, it is very important that the suppression it's very important that the exotropia develops within the critical period of time, that is 6 to 7 years of age. Okay, so if a patient develops exotropia beyond this age and if his fusion is not good, then this patient is going to have double vision. Okay, so that is the message that you must know. Coming to the fifth theory, related theory given by Knapp and Jampolsky, and that is the theory of hemiretinal suppression. Okay, and you can guess over here which part of the retina is going to get suppressed. It is the temporal retina. Why? Because this image is falling on the temporal aspect of the retina because of the outward deviation of the eye. So what happens exactly? There is outward deviation, therefore the patient is going to have diplopia or confusion. And to deal with the diplopia, what does the brain do? It just does suppression. So this is known as hemiretinal suppression because usually it is the temporal retina which gets suppressed by the brain. And now as this suppression, the patient is not going to see again double, and therefore he's going to see single, although not stereoscopic vision, but there will be a single image coming from the other eye, left eye in this case, and therefore the deviation will now become tolerable. That means the patient is not having any problem with the deviation, no double vision, and therefore deviation becomes tolerable. Now once the deviation becomes tolerable, the brain has almost no incentive for motor fusion, no incentive for sensory fusion, right? That means that because the patient is seeing only one single image and there's already suppression that has developed, it means that this patient need not now move his eye inwards or try to converge the eyes, bring back that outward deviated eye, and that is what I mean by motor fusion. Okay, so there's no incentive for motor fusion in this case, and therefore there will be progression from exophoria to exotropia. All right, so that's very important. So in the phoric stage, eyes are well aligned, okay, and that allows fusion and good stereo equity, and that's basically happening because of good fusion, right? But in the tropic phase, basically the fusion deteriorates, and now it is on the suppression, whether the patient has suppression or not, ability to suppress or not, that he will be taking care of his double vision. Okay, so in phoria it is the fusion that takes care and prevents the progression of the exotropia. But once the exotropia progresses, it is basically it depends on this suppression, whether the patient has suppression or not, and that is going to decide whether the patient will have double vision or not. All right. So again, I'll just make it clear. I'll repeat it. So whether or not fusion will occur or not, it depends upon the amount of deviation as well. Okay, so because sometimes if there's a small amount of deviation, the eyes will be able to carry out motor fusion, the brain will be able to carry out motor fusion, they'll be able to converge, and it's the amount of deviation that determines the fusion. Okay, similarly, the fusional reserve, how good is the convergence fusional reserve of the patient, that is going to determine whether fusion will take place or not. But when we talk about suppression, it's not that. In suppression, it is the time of onset of exotropia that is going to decide whether suppression will occur or not. For example, in late onset exotropia, what happens? The critical period has already passed, and therefore this patient will not be able to suppress, and therefore this patient has lost the ability of suppression, and therefore they will definitely have what is known as diplopia. Okay. Now let's talk about other sensory adaptations that you see. So basically in phoric phase of intermittent exotropia, actually intermittent exotropia, as I told you, basically is the most common type of exotropia, and it has this phoric phase which is called exophoria, then it has intermittent phase, then it has the constant phase. So in the phoric phase, eyes are perfectly aligned, there's bifoveal fusion because the fusion is good, and since the fusion is good, stereoequity is good between 40 to 60 seconds of arc. Okay, so excellent bifoveal fusion develops because the eyes are well aligned in early infancy. when the critical binocular cortical connections are being established, right? Very, very important. And next is what is known as the tropia phase. In tropia phase, the exotropia will become manifest for most of the patient, and they will show, these patients will now, most of them will show regional suppression of the temporal retina. All right, so some of them can have this hemiretinal suppression, again depends upon what is the onset of exotropia. Apart from that, some people will develop this abnormal relationship between the foveal and extrafoveal point. Okay, so as I told you that so what did I tell you? So in exotropia, suppose this is the normal eye and the rays are falling on the fovea. But in the eye which is deviated outward, the rays are going to fall somewhere on the temporal retina. So this point, fovea, this point is not corresponding to the fovea, right? So when there's a normal relationship or correspondence developing between the foveal and extrafoveal point, that is known as anomalous retinal correspondence. That is present in the second, that is something that I have explained in the second video on binocular single vision, confusion versus diplopia. All right, so ARC can also develop in the tropia phase. Okay, now a minority of patients with intermittent exotropia can also develop what is known as monofixation syndrome, where they are going to develop a very small central scotoma of the fovea, right? Now, a rare patient may even have significant amount of amblyopia. Now, let me tell you that amblyopia is not very common in exotropia, and it is actually more common in esotropia. And I would like to know from you, what do you think why this amblyopia is more common in esotropia compared to exotropia? Okay, so you can give the answers in the comment section. All right. So that was regarding the fusions, sensory adaptations in exotropia. I hope it made sense. Now let us move ahead and talk about the sixth theory as to what is the role of AC by A ratio and exodeviation. So what exactly is this AC by A ratio? We'll talk about that. But the scientists like Kushner in 1988, they had this finding that 60% of the patients who have divergence excess exotropia, they have high AC by A ratio, and 40% have normal AC by A ratio. Now, don't fret about this divergence excess exotropia. Okay, don't think about that. We'll talk about that in the classifications of exotropia. But just know that there is a role of AC by A ratio as well. In very simple terms, what exactly AC by A ratio means to you? AC stands for accommodative convergence and A stands for accommodation. So whenever there's a change of accommodation, for example, you're looking far and then you suddenly start looking at a near object. That means your accommodation is changing. Similarly, you're looking at a near object and suddenly someone introduces a lens in front of your eye. It could be a plus lens or it could be a minus lens. Now, in order to see the same object clearly, you will have to accommodate. Okay, so it basically depends. So if someone is using a minus lens in front of your eye, that means they will be basically stimulating your accommodation, so you will have to accommodate more. And if someone has introduced a plus lens in front of the eye, now you will have to relax your accommodation, because plus lenses basically relax accommodation and minus lenses stimulate accommodation. All right. Okay, so when the lenses are introduced in front of the eye, someone is trying to change your accommodation, and when the accommodation changes, convergence also changes, right? So that is called change in convergence. And basically, if you would know from my video on accommodation, during accommodation, the medial rectus will get stimulated and the eyes are going to converge. Okay, so definitely when there's accommodation, there has to be some amount of convergence as well. And when you are measuring this change in convergence divided by change in accommodation, that is referred to as the AC by A ratio. Now, there are a lot of ways by which we can measure AC by A ratio, but the most common method with which we measure it is by the lens gradient method. That means the examiner is going to introduce a certain sort of lens in front of your eye. So AC by A ratio is basically change in convergence and by change in accommodation. And we are going to talk about a lens gradient method. And the formula for lens gradient method is change in deviation divided by the lens power. And how do you calculate the change in deviation? Now over here, it is written near deviation, but you can also do AC by A ratio for distance deviation as well. For example, say we are measuring the AC by A ratio for a near deviation. That means we are carrying out the AC by A measurement at say about 33 centimeters. Alright, so we do our prism cover test and we find out that patient has about 40 prism diopters or basin, 40 prism diopters of exotropia. Now here, the sign convention is that for exotropia, you basically are going to take minus symbol. Okay, so we say the original near deviation is minus 40 prism diopter. And say we introduce a plus 2 diopter lens in front of the eye now, keeping the distance same. Now a plus lens will basically relax the accommodation. So if the accommodation goes down, the convergence will also go down. Okay, and now the new deviation is going to be somewhat less. Say the new deviation with lens in place is about minus 20 prism diopters. Okay, we're talking about exotropia, right? And therefore it's minus. So according to this method, the change in deviation will be the deviation with lens minus the deviation without lens. So with lens is your minus 20 prism diopter, and without lens is minus of minus 40 prism diopters. So it's basically an algebraic equation. So it becomes minus of minus divided by the lens that you have used, that is 2 diopters plus lens. So this become minus will become plus. So this will become minus 20 plus 40. So you ultimately have plus 20 divided by 2. So roughly about 10. Okay, so you get an AC by A ratio of 10, right? So that is how you calculate the AC by A ratio using the lens gradient method. So let us just keep it very simple. AC by A ratio basically is change in convergence by change in accommodation. And normally this is about 3 to 5 is to 1. That is a normal. So 3 is to 1 to 5 is to 1 is in within this range is the normal AC by A ratio. Okay. So you're basically finding out how much is the convergence change with the change in accommodation, right? So if a patient has say low AC by A ratio, so what does that mean? So if a patient has low AC by A ratio, it means that for a given amount of accommodation, the eyes will not be able to converge sufficiently. Because what is AC by A? It is accommodative convergence by accommodation. So you're giving some amount of accommodation, but the eyes are not able to converge very well. That means low AC by A. And definitely if the convergence or accommodative convergence is low, it means that the eyes are going to drift outwards and there will be exotropia. And when will the accommodative convergence basically come into role? It basically comes at near work. So such a patient, whenever they are trying to do some near work like the SpongeBob over here, okay, they are going to basically have this deviation of the eyes outwards because the poor accommodative convergence, and this causes exotropia at a near distance, and this is known as near exotropia or convergence insufficiency exotropia. Okay, we'll talk about this more, don't worry about that, but know that low AC by ratio can cause convergence insufficiency and exotropia at near. Similarly, what about a patient who has high AC by A ratio? Now, over here, a patient with high AC by A ratio means that the patient actually has more accommodative convergence per accommodation. That means the eyes are going to converge much more than normal for a given amount of accommodation. Now, this can cause the eyes to actually converge well for near tasks. So, near tasks are not going to be a problem. The patient is going to maintain good orthostropia. But the eyes are going to now over diverge for distant objects, creating an outward drift during distance vision task. Okay, so such a patient is now going to have more exotropia for distance vision. For example, over here, SpongeBob is trying to look past or away, and that time his eyes are diverging. Okay, so this is divergence excess exotropia because of high AC by A ratio. Okay, so simply to summarize, low AC by ratio leads to convergence insufficiency exotropia or exotropia at near, and high AC by ratio is associated with divergence excess exotropia or uh, exotropia being more at a distance fixation. Alright, coming to the last theory, and that is the seventh theory regarding the role of refractive errors, and this was given by Donders. Okay, so some refractive errors can also cause the development of exotropia, and in that we have myopia. Well, this might actually be the reason why Asians have more prevalence of or high prevalence of exotropia, because maybe they have high prevalence of myopia. Now, what exactly happens in myopia? In myopia, the rays of light are going to focus in front of the eye because the far point is located in front of the retina, right? So the rays are going to focus over here. Now, such a patient is definitely not going to try to accommodate. Why? Because if he tries to accommodate, that means he's trying to increase the power of the lens, And if he's increasing the power of the lens, the far point is going to shift even more further. So a patient who has myopia is not going to have good accommodative effort. Instead, he's not going to try to accommodate. And since he has low accommodative effort, the accommodative convergence is also going to be reduced. And since the convergence is less, there's going to be divergence leading to exodeviation. Okay, so this is how myopia causes exodeviation. Now, what about high hypermetropia? Now, we're talking about high hypermetropia, and here the important term is high hypermetropia. In hypermetropia, basically the rays are focusing behind the eyeball and the far point is located behind the retina, right? And now you might say that why not accommodate and bring these rays of light on the retina, right? Yes, that does happen, and that's what exactly is happening in latent hypermetropia and all. But when the patient has really high hypermetropia, no matter how much they accommodate, they're not going to, they're not being able to bring these rays of light on the retina. And such patients, they know it, right? And therefore, such an eye is not going to make an attempt to focus clearly or bring the rays back on the retina. Okay, so quite counterintuitive, but still, high hypermetropia, it's really high power. The eye thinks like, I don't want to accommodate such a high power, and therefore, since there's no attempt to accommodate, there's no accommodative convergence, the AC by A ratio becomes smaller, so there's going to be exodeviation. So those were the 7 theories as to why exodeviation develops. I really hope that this video was of value to you. If it was, kindly let us know in the comment section. Also, don't forget to hit that like button and also subscribe. And if you think that this video shall be useful to any of your friends, kindly do share. That's all for today. Thank you and have a nice day.